Hello everyone. I'd like to tell you this evening about a case that I saw today of a young lady in her early 40s who is a diabetic over the past 10 years and is on Invokana and metformin, which are two oral agents, as you well know. Invokana is a new agent that works by allowing glucose to escape from the kidneys. Metformin is a medication that decreases the escape of glucose from the liver. Both of these medications are currently quite popular and relatively effective. And she's had diabetes, as I said, for 10 years, and her A1C is in the 8% range, which is obviously not good enough, and she will need either a third oral agent or some insulin to bring her into the normal range, the normal range being under 7% A1C. She has complications from diabetes, mainly gastroparesis and neuropathy of her feet. Gastroparesis is not a common complication, but we see it on occasion, and it manifests with bloatingness and difficulty after eating, certain discomfort in the upper abdomen, and it usually means that the stomach does not empty in a timely fashion. This is part of the autonomic neuropathy. Autonomic meaning that it's the involuntary nervous system, the one that controls the internal organs. So controlling the stomach's contractions after we eat is part of that nervous system, and if it doesn't function properly because of injury to nerve endings, usually due to diabetes, then it doesn't empty properly, and usually after eating a meal, patients experience bloatiness, discomfort, and even pain. So this is one of her problems, gastroparesis. The other, as I said, is neuropathy in her feet, and we call this peripheral neuropathy. And that manifests with quite severe pain, electric shooting pain in nature, and she is getting for that gabapentin, which it has not until now been very effective. She is an obese diabetic. Her BMI is greater than 30. As I said, she's had this for 10 years. Her A1Cs are on 8, and she's got 2 complications. She came to see me, however, not so much because of her diabetes, but because of her hypothyroidism, which is difficult to control. She's had hypothyroidism for about 5 years, and her TSH levels are elevated. As you may know, we need to keep TSH levels under 4. TSH comes from the pituitary gland, and it controls the thyroid function, and obviously the rate at which the thyroid gland produces thyroid hormones. There's a thermostat mechanisms whereby if thyroid function is insufficient, causing thyroid hormone levels to be low, the pituitary gland gets an impulse or gets the message and immediately makes more TSH in order to stimulate the thyroid into action. So when we see in the blood tests that TSH is elevated, we can assume that thyroid hormone levels are low. And if the patient is hypothyroid, that means that he or she are under-medicated, which means we need to increase the dose of the levothyroxine, which is the name of the medication. There are a few brand medications on the market, such as Synthroid or Levothyroid, but today most patients resort to the generic, which is inexpensive, and it's called levothyroxine. So as I said, this patient is taking 200 micrograms of levothyroxine, and her TSH levels were in the 30 range, and they need to be under 4. So the connection here is that the patient has gastroparesis, and because she has gastroparesis, her stomach does not empty properly. We tell all our patients who are hypothyroid and take levothyroxine to take the pill on an empty stomach and wait with breakfast for about 30 to 45 minutes, because we want to make sure that the levothyroxine gets absorbed properly into the bloodstream. In this patient's situation, things are a bit different in the sense that she has gastroparesis, and consequently the pill probably lingers too long in the stomach, and most likely because of the acid environment in the stomach, the pill disintegrates and never reaches the bloodstream. Therefore, her thyroid hormone levels are always low, and TSH consequently is always high. What to do in these cases? One of two things can be done. The first and easy one is simply increase the dose of the levothyroxine, which is what I did. I told the patient basically to double her dose. She's now going to take 400 micrograms. Some patients need to take even 500 micrograms, and that is simply because it takes a lot more to bring up the thyroid hormone levels in the blood. Some of it gets absorbed, but eventually enough gets absorbed. So that's the first thing that I did. The other thing that can be done and should be done with a patient who has gastroparesis because of diabetes is to give a medication which we know can enhance the emptying of the stomach. This medication is called Reglan, and it's taken prior to the meal. Just prior to the meal, it's 10 milligrams, and it enhances the emptying of stomach content. Patient was given a prescription for that as well, and told that she should try that and see if it eases some of her symptoms. If this eases her symptoms, that would mean that she is moving the food forward. That would also enable the better absorption of her levothyroxine. So that's the action that was taken for her hypothyroidism and gastroparesis. Regarding her peripheral neuropathy, the patient was sent for nerve conduction testing, and she might need to see neurology in the future depending on the results of that test. Of course, underlying all of this is the need for better control over diabetes, and at this point the dose of the metformin was raised, but the intent is in the future to possibly send her for a gastric bypass, and if that is not agreeable, to try one of the medications that we have to suppress her appetite and increase pancreatic secretion of insulin. We can talk about that in the next patient that I shall discuss. I hope this has been helpful. Have a nice evening, and see you next time.